So let's get through this. Diencephalon is the thalamus and hypothalamus. Nobody missed that. What part of the brain regulates breathing pattern and depth? That is the pons. Rate is in the medulla. Rage and anger come from the limbic system. Balance and equilibrium is the athlete's brain, your cerebellum. Chemicals that relay electrical signals from one nerve to another are neurotransmitters. Which of the following nerves is responsible for airway control? The trigeminal, that's a lot of the facial movement and keeps the airway. It's not your, definitely not your abducens or trochlear. Trochlear is your hearing. It has nothing to do with airway. When assessing a response to pain, you see that the patient does not respond. What should you do first? Of these choices, check the airway. He's already sedated. Which is the following cause of trismus? What is trismus? Lockjaw. Okay, it's almost always cerebral hypoxia. Head injury found lying supine, feet are extended with toes pointed, arms are extended with hands pronated. Right, he's in decerebral or flexion, or I'm sorry, extension posturing. So this would be decerebral, not the corticate. Not necessarily a spinal cord injury, it's more of a brain herniation, brainstem injury. Which would indicate dysfunction of the trigeminal nerve? Trigeminal nerve is right here. So you can't feel part of your face. You have a hard time moving part of your mouth. It has nothing to do with eye movement. Okay, it is not shrugging your shoulders. That's cranial nerve 12. And it's not moving your tongue. This is the one that runs right across your face. Just below your eye, on your upper lip, and just below your lower lip. Stroke on the right side of the brain would cause left-sided weakness. In contrast to shock, someone with increased ICP has a widening pulse pressure. The top and bottom numbers of the blood pressure get further apart. Which of the following cranial nerves, when asked the patient to move or follow your finger as you move it in age. Right? The big one is that is oculomotor, also a little bit trochlear and abducens, but oculomotor. Eye movements, the only one that has eye movement as an option. Management of a patient with a neuro emergency begins with making sure you're safe. So this is a very typical state/national test question. If your safety is an option, it's almost guaranteed that is the correct answer. Now I get, it says management and you're thinking treating the patients, but it's still always, your safety is part of management. Is that your argument?
Wow.
Yeah. Sorry. Yes, management is always going to be safety first. Not just neuro, in any emergency. Patients with trismus, lockjaw, require usually a sedative or a paralytic to manage the airway. Can't manage the airway if their jaw's locked. Arm drift, one arm drifts towards the body when the eyes are closed, nobody missed it. Tremors as somebody reaches for something or gets closer is intentional, nobody missed it. Rhythmic contraction and relaxation of muscle groups during seizures. This is the clonic phase. Tonic is the rigidity. Clonic is the rhythmic shaking. Hypertonic is an extreme rigidity, almost like arching their back. Elderly patient at a nursing home found unresponsive. Respirations are slow and shallow. Heart rate is slow, weak, and irregular. Skin is cool and clammy. Other than looking for a DNR, you should. No. Because he's breathing slow and shallow, we need to start bagging him, and let's start looking at oxygen levels. Do we need a 12 lead? Eventually, but not immediately. Checking his sugar? Eventually. Okay. I agree with high flow O2, except he's breathing slow and shallow, he needs a BBM. Pre-hospital treatment for a patient with suspected stroke who recently had a seizure includes what? The seizure.
Pams and lambs.
Yes, so we stop or control the seizures. Please, let's not give aspirin to our stroke patients, because if this was a hemorrhagic stroke, we just dug that grave a little bit quicker for them. Which is the example of acute cerebrovascular emergency, right? Also known as a stroke. Right? A clot blocking a cerebral artery. So accumulating of plaque, yes, that's bad, but that doesn't mean it's a stroke. It's not a stroke until it blocks the vessel. Right? Numbness and tingling, that doesn't mean it's a stroke. It could be a pinched nerve or frontal headache with sensitivity to light. This is more of a migraine. According to the Los Angeles Stroke Screen, the possibility of stroke is increased if they have a normal blood sugar. Okay. If they are older than 45, not younger. So, your question, Destiny? Or was that just a stretch?
I was a little confused on this one because I got it on the quiz.
Mm-hmm.
And I was confused between, because it has both the blood glucose one and it has the bedridden patient as well.
Okay. So their risk, right, the possibility of a stroke, so we think it might be a stroke. The possibility increases because blood sugar is normal, meaning it's not blood sugar. If the blood sugar was abnormal, what do we call a stroke? No. All right, so that's what, it's not the greatest worded question, I'll give you that. When nerves are deprived of oxygen and glucose, they convert to anaerobic metabolism, just like any other cell. CPP, when you have a mean arterial of 80 and an ICP of 5, 80 minus 5 is 75. Hyperventilating a patient with increased ICP does what? Constricts the blood vessel and decreases blood flow to the brain. It's a very temporary fix, and it's kind of controversial. 59-year-old woman with acute onset of confusion, left-sided weakness, right-sided facial droop. Okay, airways patent, she's breathing adequately, blood pressure is okay, heart rate's okay, she's in AFib. When obtaining a medical history, what is the most important question? When did it start? That's going to determine treatment. Elderly man, confusion, facial droop, left hand is weaker than the right, type 2 diabetic. We should rule out blood sugar and suspect right-sided stroke. Middle-aged woman, generalized weakness, 18 hours ago, right-sided weakness, left-sided facial droop, unilateral, or bilateral equal reactive pupils. Excuse me. Blood sugar is 70. En route to the hospital, she's got increased movement in her arm. So what are we thinking here? TIA, even though it's been 18 hours, it still could be a TIA. What should we do? Even though it's most likely a TIA, we're going to treat it like it's a stroke. 19-year-old decreased LOC, no medical problems. Initial treatment would be, she's got an airway and breathing. If safety was an option, safety would be your better choice. Local pharmacy, 24-year-old woman had a seizure. All right, she's conscious, combative. Supervisor states she has a history of seizures, takes Tegretol, blood pressure, heart rate, and vitals are all good. Treatment for her would be give her some O2, establish an IV, transport. Sir?
Why would we not want to do the diazepam and lorazepam?
She's not having a seizure. She had.
But you can use those for chemical restraint since she's being combative, can't you?
Okay, but why is she being combative here? She's confused from the seizure. Right. We're not chemically restraining those. Chemical restraints, my personal opinion, not curriculum, my personal opinion, we don't need it.
Okay.
It's horrible, horrible, horrible. Rare circumstance. I've been on calls, I think in my career, I've needed to have chemical restraints on one person.
Okay.
You know, I've seen it done way over aggressively. one lady's like, this is a bunch of crap, all arguing, and they're like trying to sedate her. I'm like, whoa, what are you doing? So I get what you're saying here, combative, right? Giving her a benzo to reduce her combativeness. Yeah, it's usually not our drug of choice for combative patients. We'll usually go with more of a tranquilizer like a Haldol or a Geodon or something like that.
Okay.
7-year-old girl had a seizure. According to mom, she was sitting at the table, stopped speaking, and started blinking her eyes. It lasted less than a minute, and then her condition rapidly improved. This is an seizure. 18-year-old son brought to your station. He's actively seizing. He's been seizing for 10 minutes. Has a history of seizures, takes Depakote. He's cyanotic, breathing erratically, and generalized muscle twitching. You should, okay? We don't put anything in his mouth. Protect him from injury, intubate, no. All right. So you're putting something in his mouth. Hyperventilate to get rid of carbon dioxide. There's nothing there to indicate that's needed. Open his airway, assist him, start an IV and IO, and give, in this case, they had Valium, but you could go nasal Versed or Ativan or any of your benzos.
Question on that
Sir.
one as well.
Yes, sir.
Now I know we don't put bite marks anymore, but isn't it in our book that we still do?
No, nothing
No?
goes in the mouth.
Alright, I was gonna also
Nothing,
say,
nothing.
I didn't think we wanted to go at them with an IV or an IO if they're still actively seizing. So that's why I went with the IM.
I can understand that, but this is a definite no-no, because what happens
Okay.
here is either they're going to bite what you put in their mouth, and now you have an airway obstruction, or if it's hard enough, they're gonna break their teeth on it, and now you have an airway obstruction.
Understood.
Nothing goes in the mouth.
Obviously.
33-year-old, apparent syncopal episode. She complained of dizziness, right? He caught her before she fell to the ground, no trauma. She's conscious but confused, sitting in a chair, blood pressure 90, heart rate 110, respirations are 22, regular blood sugar 74. Of these choices, most likely cause, do you think she had a vagal stimulus, like trying to bear down on a toilet? If it said on the toilet or having a bowel movement, I could see that. Do you think she had a seizure? Do you think her sugar is suddenly low and miraculously came up on its own? Or she's dehydrated? 44-year-old, severe headache, laying on the sofa, wet washcloth, history of migraines. This is typical for her. Nausea and what's photophobia?
Sensitivity to light.
Sensitivity to bright light, blood pressure is elevated, heart rate is elevated, breathing is slightly elevated. Most appropriate treatment for her would be, right, are we giving her morphine?
No.
No. Right. Putting her in some followers, transporting her. Oxygen, IV, Zofran, why Zofran? Nausea, right. Nitro for blood pressure, definitely not. So, yeah, Zofran's the best option. 51-year-old, headaches, worsened over 3 months, called 911, severe nauseated, vitals are stable. All right, you've been taking Tylenol for his headaches. You should be most suspicious of a tumor. Yes, worsened over 3 months. 29-year-old man, recently given antipsychotics, bizarre contortions to the face. What is that? Dystonia, so he needs Benadryl. Which of the following are consistent with meningitis in an infant? Okay. So the key here is it's an infant, so they have fontanelles, and meningitis is inflammation of the meninges, which is going to cause them to get inflamed and bulge out. Right? So bulging fontanelle, not depressed, that would be a sign of what?
Dehydration.
Dehydration. Okay.
Sounds like someone really fucking killing that dog out there. Need some WD-40 on the wheels.
Yeah. Among other functions, the medulla Full blood pressure and heart rates. A synapse is the gap between two nerves. Okay? Where the nerve ends is the terminal motor plate or end plate. Right? A cluster of sensory nerve cells is, can't think of the word now. Anyway, a synapse is the gap. Disceravent posturing. Okay? Right. So this is decorticate, disceravent is out and away. So this would not be flexion of the arms. It is worse than decorticate, so it's not less severe, it's more severe. Right? More severe than decorticate in case damage near the brainstem. In contrast to shock, patients with increased ICP have widened pulse pressure. Not the same question, worded slightly differently, but basically the same question as one earlier. Patient with one side eyelid drooping when smiling. Might be Bell's palsy. You just see the eyelid down, but not the whole face. It's almost always Bell's palsy. Oculomotor, trochlear, and abducens nerves control what common function? They all have to do with eye movements. Intracranial pressure rising, you may get herniation of the brainstem. Brain doesn't become hypocarbic. That would be low carbon dioxide. You actually get high carbon dioxide. Probably hyperventilate, blow off the carbon dioxide. Which of the following causes sustained increased ICP? Tumor, again worded differently than that other scenario question. Patients with increased ICP, you must maintain blood pressure. That's a big one. People are like, well, I think it's a head injury or a stroke. You've got to have your blood pressure. 39-year-old has acute hemorrhagic stroke. She's responsive to painful stimuli, has bilaterally dilated, sluggish pupils, breathing is slow and irregular, blood pressure is low, heart rate is 40 and pounding. Of the choices here, she needs BVM because slow, irregular breathing. In contrast to syncope, a seizure can occur in any position. Syncope usually does not happen if they're lying down. Somebody lying down doesn't suddenly feel faint. They usually have to be upright. Which of the following would most likely be performed on a stroke patient in a pre-hospital setting? Are we giving them aspirin?
No.
Are we bringing their blood pressure down?
No.
Are we doing clot busters in a pre-hospital setting? Of the choices, innovation most likely is what we're going to have to do. Not saying they all get innovated, but of the choices, that is the best answer. All right, which stroke center is capable of giving thrombolytics and then transferring them to a higher level? Stroke center. Definitely not any level 3 hospital. Okay. It is a stroke center. It is not a comprehensive. Comprehensive stroke centers can do all of that and do rehab in the facility. A primary stroke center can do thrombolytics and do surgery. A stroke-ready hospital can give thrombolytics, but that's it. So if there's anything else that needs to get done, or if they need surgery, they have to transfer them out. That was in that little chart explaining the differences. Yes, sir.
Do we have any stroke-ready hospitals in Volusia County, or are they all primary?
Can you transport, and I'm not 100% familiar, can you transport a suspected stroke to every hospital, including standalone, well, all right, every hospital, not standalones?
I don't think these.
Yeah, standalones you shouldn't.
And not Port Orange.
Okay, so Port Orange could be considered a stroke-ready hospital, but they're going to transfer them out. Your protocol basically says, we're just gonna go to the comprehensive or the primaries, and that's based on your medical record. There are some regions in the country where the primary stroke center can be many, many hours away, and it's still like, well, we'll get them to this one first, let them start the thrombolytics if necessary, and then transfer them. kind of like the STEMI, I don't personally agree with it, it kind of delays the overall care. But again, do you want to transport a stroke patient for a couple of hours in the back of your truck? So, Robbie?
The only hospitals that are not stroke facilities are the Advent Health in Deltona, the
Standalone
Advent
ER.
Health in Port Orange,
Standalone ER.
and then the Halifax Health in Deltona, and then
That's not a
Parish. All the others are primary, and then the only one that's, that can take something higher is Halifax, and it's only because they can have a higher weight.
Psychiatry is comprehensive now too.
So Halifax and Advent, Daytona are both comprehensive. Everything else is primary,
Is a primary,
except for the
the
standalones.
standalones.
Right, which we should never be taking a supercritical patient to standalone. Some people are like, well, I'm working a code, we're going to standalone. It's like, but what if you can get them back? What if they get them back? What's gonna happen? And what are they gonna do in that code that you're not already doing? 56-year-old diabetic, numbness, tingling to both hands, gradually intensified. She's got stable vitals, blood sugar 190, right? She's eaten but not taking her insulin. Give her a ride to the hospital. Right? Suspected meningitis flexes their knees when their head is moved toward their chest. This is Brudzinski's sign. Parkinson's, when they're asked to turn, they take small steps until the turn is complete. That small, slow movement is bradykinesia. Peripheral nervous system is responsible for sending messages to and receiving messages from the brain. Everything outside of your central nervous system. Autonomic functions is central nervous system, thought perception, right? That's central nervous system. LOC is regulated by your reticular activating system. All right, let's review the Glasgow score.
RPOQ2, I'll victim of it.
So, patient is found discerbate. What does that mean? Decorticate, this is discerbate. So on the motor side, what do we have? Obey command. That's a 6. Can withdraw from pain. Can localize pain. Decorticate. Discerbate. Nothing.
1.
Discerbate is a 2.
So I didn't even read motor skills, right? I just saw GCS and I was like, well, 3's dead. There's no way it's 2. So that's where I went with that. Just the RTFQ thing.
Yep.
Yep.
Unresponsive patient, trismus can indicate cerebral hypoxia. Again, similar question to earlier. Patient is experiencing a psychosis. Ensure you are, first thing you do, ensure your safety. Immediate and significant complication with a hemorrhagic stroke. What is going on? They're bleeding, right? The biggest complication here, are they gonna get shocky? Eventually, but not the immediate complications. Immediate complication is gonna be ICP.
Oh, I got this right.
Yeah. So with ICP, we get hypertension and bradycardia. Yeah, but that's not the problem. The problem is the ICP. High level of oxygen to the brain with a hemorrhagic stroke and increased intracranial pressure can cause vasoconstriction and impair brain perfusion. That's why they don't like high concentration oxygen to your stroke patients. Just enough to keep their SATs above 94. EENT, okay, cranial nerve that innervates the muscles and causes movement of the eyeballs and upper eyelids. That is the oculomotor eye movements. Optic is what?
Vision.
Vision. Okay. When removing contact lenses, only if there are chemical burns to the eyes. The middle ear, right? There's the 3 little bones in there, the ossicles and the tympanic membrane. Inner portion of the tympanic membrane and 3 little bones, the ossicles. What are the names of the bones?
Incus, malleus, stapes.
All right, incus, malleus, and stapes. Hammer the anvil in the stirrup. Signs and symptoms of otitis media. Otitis. Inflammation of the ear in the middle ear infection. Okay. They don't get hypersensitive to sound. It's not like their hearing improves. They don't get bilateral ringing in their ears. They hear it on one side because the ear infections are usually one-sided. They may get vertigo, but usually not violent vomiting. Okay, but their tympanic membrane is all inflamed and maybe bulging out because of the inflammation. That's what the doctor is looking for when he's looking in your ears. He's checking your tympanic membrane. Aqueous humor is in the anterior or front chamber of the eye. That's the stuff that can be replaced. Vitreous humor cannot. Disconjugate gaze. That's like chameleon, eyes glued independent. So somebody got hit in the head or face or something and their eyes are not moving together. We did have fun with one of our rookies at work, because one of our guys has a really, really super lazy eye, and it like deviates off to the side all the time. And he'll like look around and freaks the rookies out. He's the same guy, he shaves his head bald, but he'll wear a wig, like a toupee on purpose. And we tell all the rookies, like, hey, he's really sensitive, don't talk about his hair. And he's like got a little foam head, he puts it on and everything. It's like the Donald Trump comb over. It's all a joke. And usually we let the rookie in on it after about 3 or 4 years. Glaucoma is caused by increased pressure in the eye, increased interocular pressure. Vertigo or loss of balance following an ear infection or upper respiratory infection is consistent with labyrinthitis. That's the inner part of your ear that helps you balance, helps, and if I'm not feeling balanced, if I'm feeling dizzy, vertigo, I'm guaranteed labyrinthitis. It's not an external ear infection. It's definitely not impacted your legs. Epiglottitis have difficulty swallowing, dysphagia. Okay. Signs of TMJ. Their teeth don't line up when they bite, uneven bite. In contrast to oculomotor, so not the oculomotor, the optic nerve is the sense of vision. A lot of people struggle with these type of questions in contrast to this or as compared to this. Basically, you can take this part of it and just draw a line through it. The optic nerve, what? When examining the orbital rim, right, what are we looking for? Bruising, okay, or fractures. The large external portion of the ear, Mike Tyson's favorite delicacy is the auricle, also called the pinna, either term, auricle or pinna. Pathophys of Meniere's disease, okay, swelling of the inner ear that affects the ear, producing dizziness, loss of balance, and ringing in the ears. It's not dysfunction of the eustachian tube. That's the part that drains extra fluid out of there. You hear of little kids getting tubes put in. That's the tubes they're talking about. As they grow, the tubes just fall out. So the angle of that doesn't damage the organ of quartile.
That's the right answer.
I will check this one. And a non-trauma patient bleeding from the nose, you can hold it for 20 minutes.
Dumb question. Get rid of it. Not everybody.
Oh,
I had both of those.
Dave, did you do anything where you say a lot of words at one time?
It's
It's
in
in
there.
there.
We're just asking you to do us a
Swear,
favor and
Brandon,
throw it out.
definitely.
We're not saying
It's
it's not in the book verbatim.
We know for
That's what I'm saying, you can hold that nose for 20 minutes?
Fuck, yeah. The other things going on in the city. Tens and ends. The other emergencies.
I read that chapter. Not a lot.
That's really excessive.
I put 10 too.
All right, Meniere's disease. It's damage to the organ porti, that's my error, but I will take this one also.